All right, well, good afternoon, everyone. As you heard, my name is Christopher Hess. I'm a movement disorders neurologist here at the University of Florida. And our topic over the course of the next 40 minutes is pain and fatigue in Parkinson's disease. And I chose this topic because I think this is something that we as movement disorders specialists continue, despite our best efforts, to not do a great job of addressing. And so what I hope to do today is arm you with the information and the background that you need to go into your visits, whether it's with us or other providers, with as much of an understanding of the lay of the land and what's required, what type of workup needs to be done, and how to approach pain and fatigue in Parkinson's disease, because it can be extremely challenging to make headway. So this is the structure of the pain component. I'm going to spend most of the talk on the pain component because there's a lot more information to go over. But afterwards, we'll talk about corollaries in fatigue, and hopefully we'll be able to get through everything and get everyone to lunch on time. I think we may have a slide. Oh, okay, we got it back. Okay, so starting with pain. So James Parkinson in 1817 provided the first description of Parkinson's disease based on 3 patients that he saw and 3 patients that he observed out in the street. And he was remarkably accurate in describing all of the features of Parkinson's disease. And he actually described pain as a feature of Parkinson's disease in the initial description. So we have known that pain is a part of Parkinson's disease since the very first description of the disease, and most of the major papers early on in the first 100 years after that recognized it as well. The prevalence of pain in patients with Parkinson's disease is very high. So it's estimated between 40 to 85% of patients. The prevalence tends to go up the longer people have had Parkinson's disease. So when you think about the fact that we've known about this from the very beginning of the description of Parkinson's disease, and so many patients have it, why is it that we overlook it as a symptom of the disease to such a degree that we do? Because just by a show of hands, how many people in the audience experience pain as part of their Parkinson's symptoms? So a good number of people. And also, how many patients experience fatigue as part of their symptoms? A good number of people as well. So in being overlooked, at least initially, pain and fatigue had good company. So for quite a long time in Parkinson's disease research, we focused on the motor symptoms of the disease. These are the features that everybody associates with Parkinson's disease. You're stiff, you're slow, your movements are smaller. These things are the characteristics of the disease. But despite that fact, the non-motor symptoms of the disease for many patients can actually be more disabling than the motor symptoms. And so this list that I have up on the screen of all the non-motor symptoms of the disease also were neglected for a long portion of the period that we've been studying Parkinson's disease, and I'll just go through them briefly individually. Cognitive impairment has, over the course of the past 10 or 15 years, been really, there's been an increase in the amount of research that we're doing with regard to that. It is definitely a part of the disease, as well as eventual Parkinson's disease dementia in some patients. Depression and anxiety is very prevalent in patients with Parkinson's disease. Some of it is due to dealing with the symptoms of the disease, and some of it is just due to the disease itself, has nothing to do with the actual symptoms that it causes. Sleep disturbances is a well-known part of Parkinson's disease now, so some of you may have REM sleep behavior disorder where you act out your dreams at night. Many of you probably have disordered sleep, difficulty staying asleep, difficulty falling asleep, and not feeling refreshed in the morning. So that's an important part of the disease as well. Gastrointestinal abnormalities, primarily slow transit constipation. We've gotten much better at talking about this. So you go in to see your movement disorders neurologist. For the most part, all of these things, urological sexual dysfunction, orthostatic hypotension or getting dizzy when you stand, visual and sensory disturbances, sometimes patients who are on higher doses of Cinemed who've had Parkinson's disease for a while can develop visual illusions or a sense of presence of someone being in the house with you. And patients can develop apathy or difficulty enjoying the things that you normally would enjoy and caring about things in the same way that you used to. So we do a pretty good job of asking you about all these things every time that you come in. We don't do a good job of talking about pain and fatigue. And if you ask about it, very often if we have 5 minutes left over, we've only got a little bit of time to devote to it. And so, despite the fact that we've not done a great job of addressing this, both in research and clinically, it's really important that we do so. And so why is it that it's so difficult to address? Well, one thing is pain is not a simple sensation the way that temperature or vibration or touch is. It is a complex perceptual experience. Everybody experiences pain differently. There are emotional components of pain. There are motivational components that can modulate pain, and cognitive components. Pain can be different in people based on their understanding of the situation. Pain can be subjective. So what can be painful to one person, just based purely on the physiology of the signal, to another person might not be interpreted as pain. So you can imagine how difficult that is to study in groups of hundreds or thousands of people. From the clinical standpoint, many patients have more than one kind of pain. So if you're coming to your visit with your movement disorder specialist and you say, I have pain, you could be talking about a huge amount of a variety of different things all going on at the same time, and we could spend your entire visit and probably double that just talking about the pain and never get to all the other aspects that Parkinson's touches in your life. So patients with Parkinson's disease, despite this complexity, may also have other medical problems that are contributing to their pain. So multiple things are going on at one time. Most of the patients in the age group that develop Parkinson's disease have pain anyway. 30% of patients in the age group that most of you are already have pain for other reasons who do not have Parkinson's disease. And finally, the studies that have been done to date for all of the reasons that we just talked about have been relatively poor quality and have shown variable results. With regard to associations to motor symptoms, it's dependent upon the study. With regard to association of the non-motor symptoms, it's also dependent upon the study. So there's a lot of variability there, and it doesn't provide us with a lot of guidance about what to do. Despite the fact that we don't do a good job at this, it's extremely important that we continue to try to get better because it's so prevalent. We talked about the prevalence can be up to 75–80% of patients. It can be a dramatic factor in people's decreased quality of life in Parkinson's disease. In some patients, it can be the number one predominant symptom that you're dealing with. In some patients, it can be the presenting symptom. That's the very first thing that you experience in Parkinson's disease. And it can be associated with depression and apathy as well. So it's hugely important that we do the best that we can to address this, both from a research standpoint and from a clinical standpoint. So what I'm going to try to do today is lay out what you're dealing with regard to the complexities in dealing with pain and try to optimally prepare you to go into your movement disorder specialist or your neurologist's office and make the best use of your time. So during that time that you have with your specialist, they are focused on you for the half hour that you have if you're an academic center. If you're in a private practice, they may only have 10 or 15 minutes to give you. So you need to optimize and have every tool ready to make the best use of that time to get your pain addressed. So this is a classification of the types of pain. So this was developed by Blair Ford, a colleague of mine at Columbia University about 10 or 12 years ago. Before this, there was a number of different ways that pain was being classified, but this is what has stood the test of time. And this is what we're going to be talking about today. So there's musculoskeletal pain. There's pain due to dystonia or dystonic pain. There's nerve-related pain, which is also called neuropathic pain or radicular pain. There's primary or central Parkinsonian pain. There's restlessness or akathisia. Now, this isn't as common as some of the others, but some patients experience this, and I'll talk a little bit about it as well. And then I've added gastrointestinal pain because there is a specific subgroup of patients who actually experience pain, gastrointestinal visceral pain, that is, to this day, still not really well recognized. It's not part of the official classification of Parkinson's disease pain. So, musculoskeletal pain in Parkinson's is the number one cause of pain. So how is it that the symptoms of Parkinson's disease are giving rise to musculoskeletal pain? So if you think about it, all of us, our whole lives, have had the same neural pattern of activity that's given rise to muscle movement. Now, when you develop Parkinson's disease, now we have rigidity to deal with, and we have bradykinesia, and you're moving slower, you're stiffer, your movements are smaller. And so how does that affect you? in order to do the same type of postures that we do on a day-to-day basis, you need to engage different muscle groups or different muscle patterns. Now, for example, patients with Parkinson's disease often will develop a stooped posture. Their neck will start to fall forward. That produces very abnormal muscle strain on muscles that normally are not that taxed. When you have decreased arm swing in your shoulder, you can develop a frozen shoulder, decreased activity, and a lack of arm swing can actually change the way you walk, and it can change the way you reach for things, right? When you're walking and you have decreased step size and you're taking smaller steps to turn, when you go to sit down in a chair, you have to do it very carefully. You're using different muscle groups than you've ever done before. So everything your body has learned over the course of your life has now changed because of the symptoms of Parkinson's disease. So this gives rise to awkward body mechanics, right? So everything that you've done is no longer the same. You're having to adjust. And so when you adjust, you're developing pain and you're getting these unusual musculoskeletal stresses. So tendons are getting pulled in ways that they never have been before. You're developing pulling of muscles or nerves, and then muscles are tensing around that to try to protect it. And that's giving rise to musculoskeletal pain. So all of these things give rise to the final result, which is muscle cramps and joint-based pain. And you can see how the process of this would go. And it's difficult because many patients in your age group already have musculoskeletal pain. So this is happening on top of whatever musculoskeletal pain people in your age group would be experiencing normally, right? It's all combined together. So this is just a mention of some of the things that we talked about. The cramping or aching can occur in the neck, back, arms, or calf muscles, and musculoskeletal pain. Joint pain, when it occurs, is often in the shoulders, hips, or knees. I'm sure there's many of you out there that are experiencing this. It can be more pronounced in the more prominent side with regard to your symptoms, but it can also be bilateral, so it's variable that way with regard to patients. It may or may not be related to your motor fluctuations. So there are patients who, when they turn on and their medications are working well, their pain goes away. And when they experience off phenomenon, when the medications are no longer working, their pain comes back. For some patients, it has absolutely no relationship to your on and off and your motor fluctuations, and you're in pain all day long. For other patients, it does fluctuate, but there's no temporal relationship between the on and off phenomenon or motor fluctuations. So huge amounts of complexity. In some patients, it's just in the morning or it's just in the afternoons. In some patients, it can correlate with your total overall level of disability. So when we have you doing that test where you're tapping and opening and closing and turning that you're all experts at now, sometimes we can find correlations between that and the degree of pain that you have. And it can mimic other systemic disorders like rheumatoid arthritis. So very, very difficult to sort all of these things out. When you have musculoskeletal pain, it can give rise to spinal deformities, right? So if you have abnormal stresses on the vertebra of your spine, you're developing narrowing of the canals which the nerves go through, and you can develop radicular pain, or you can develop nerve pain. When that increase in the vertebral size gives rise to inflammation and bone growth, sometimes it can develop spinal stenosis, right? So it's all connected, and although patients in your age group can develop these things anyway, it's much more complicated when you have this on top of what you're already dealing with. So that's musculoskeletal pain. It's the most common type. Next is dystonic pain. And I think we should just sort of take a step back and think about what is dystonia, because often when we're in the office, we'll be asking, do you experience dystonia? Do you experience pain? And patients are thinking, I still can't figure out what's dyskinesia and tremor. How am I supposed to know what dystonia is, right? A lot of people experience that. So when we talk about dystonia, what is it that we're talking about? So this is a little bit of an older definition that I find the most useful when talking to patients. So it's a syndrome of sustained muscle contractions that causes either twisting or repetitive movements or abnormal postures due to co-contraction, contraction at the same time of both agonist and antagonist muscles, right? So if I go to do a movement, whether it's a reaching movement or any kind of movement, I need to activate the muscles required to produce the movement. I need to inactivate the muscles that are required to allow the relaxation to happen, right? Because if the whole arm is relaxed, it'll just shake. And so when you have dystonia, in addition to activation of the muscles that you need to activate, you also have activation of muscles that are not involved in the movement at all. And you have activation of muscles that are specifically supposed to be relaxed to allow you to do the movement. And so all of this can give rise to pain. Pain that's secondary to dystonia can occur during off periods or on periods. And when dystonia mixes with musculoskeletal stiffness, you can develop contractures. So there are some patients who you've seen who develop, and some of you might have this, the fingers get sort of flexed at the most proximal joint, and then they arch upward. It's called a striatal hand, and this can happen from the combination of musculoskeletal pain and dystonia. Dystonic pain can occur at rest or with movement. When it's off, because we said it can be off or on, usually if you're going to experience off dystonic pain, it's going to be your toes curling in the morning. So you wake up in the morning after not having some Cinemet and your toes curl downwards. Or sometimes maybe the toe goes up and you keep wearing out your shoes because you've got that little ridge where it just constantly is rubbing on the top of your toe and causing pain. Some of you might have experienced that. Or maybe you have the experience of your foot turning in when you're trying to walk and you go to put your foot down and it's turned in and tilted down and you're not walking normally, which you can imagine what that does to your hips, right? So that's another way that the different types of pain are connected. And it, as I mentioned, can contribute to the development of contractures. So that's dystonic pain, musculoskeletal pain. What about nerve pain? So this is another common one. Not quite as common as musculoskeletal pain, but very common. This is pain that's due to either a problem with the nerve or where the what's called the radicular component, where the nerve starts to exit the spine. And it can produce burning, tingling, numbness type of sensations. What allows us to know that this is the type of pain that's going on is it occurs in the distribution of a specific nerve. If it's the median nerve, if it's the ulnar nerve, it occurs in that distribution. If it's a root that's coming out, it occurs in the muscles and the skin that's innervated by that root. So that's what helps us to determine when someone's having neuropathic pain. It can also lead to postural deformities, immobility, and repetitive dyskinesia or tremor can predispose to the development of this. There's also some literature to suggest, and many of you might have come across this, that the treatment that we provide for Parkinson's disease can give rise to or contribute to neuropathy. So you'll see this in the literature. It's a big question. Is Cinemet contributing to neuropathy? Is neuropathy happening on its own? Now, this is an active area of research. Everyone, I think, agrees that the benefits of Cinemet at this point outweigh the negatives and the possibility of developing neuropathy. But it's something that needs a lot more attention. And if you're experiencing neuropathic pain, it may be helpful to talk to your movement disorders neurologist about it, because there are other tests that can be done. They can look at your B6 level, they can look at your B12 level, and decreases in these vitamins have been associated with neuropathy in patients with Parkinson's disease. Not a lot of you are going to experience this, but if you do, you may have never had an explanation for it. So some patients experience, this is a Rembrandt, it's harder to see in the picture here, but it's a ship at sea in very, very rough waters. And so some patients who have Parkinson's disease, either throughout the day or periodically, will experience a subjective feeling of inner restlessness. It's not like the restless legs that you feel where your legs feel uncomfortable and you have to move them and that allows your legs to start to feel normal again. It's a general feeling of restlessness. You don't want to get up and walk around because you're tired, but you don't want to sit still. You just feel overall, you're intolerant of remaining still. So this is a type of pain that can occur in Parkinson's disease as well, because so pain we talked about is a complex factor, but the signals that create pain are signals that are coming from the periphery, the same type of signals in general that causes other sensations. So we need to recognize this when it occurs, because there are specific treatments for it that are different for other types of pain. This is the addition that I have to the classification of pain, and that's gastrointestinal pain. I have a number of patients that experience bloating, gas pains, dyspnea. Sometimes you feel like you're having a heart attack for some patients, and it all can be associated with the decrease in the speed at which food moves through the gastrointestinal system. We all know that constipation is a part of the disease. Some patients can have delayed gastric emptying, so medications don't work as well, and sometimes it can back up and actually cause problems with heartburn. So that just shows how complicated Parkinson's disease is, because it affects every system of the body. So this is also under-recognized. Central or primary pain in Parkinson's disease, from the neurologist's point of view, is probably the most interesting, and most interesting from a scientific standpoint. For you all, I don't think any of the pains you experience would be described as interesting. However, this is the one that is directly related to the brain and function in the brain. It's variably described by patients as a diffuse burning, cramping, a stabbing, and aching pain. It can be more on the area of the body that's more affected by Parkinson's disease. It doesn't follow a nerve route or a radicular format the way a nerve type of pain is. And it can sometimes affect very unusual areas like the genital area or the mouth. And when that happens, patients will see a dentist or perhaps someone, no one will make the connection that this can actually happen as a part of Parkinson's disease. So also very important to recognize. The reason that central pain occurs in Parkinson's disease is that the basal ganglia, the part of the brain that we're always talking about, right? The decrease in dopamine in the basal ganglia and the loss of cells in the substantia nigra decreased dopaminergic levels in this area. So this area of the brain is also involved in pain processing. And the basal ganglia itself plays a role in the experience of pain, right? Because we said it's a very complicated experience. So our best guess right now is that dopamine depletion actually amplifies the sensory information that comes to the basal ganglia. And so things that wouldn't normally be painful when you have a basal ganglia that's affected by Parkinson's disease is going to be experienced as painful. Now, in addition to that, other parts of the brain that are classic for pain involvement that everybody's been studying in pain neuroscience for years can also have the Lewy bodies that Dr. Oken was talking about this morning and that Dr. McFarland studies. And so that can also give rise to the central pain that people can experience in Parkinson's disease. And prior studies have shown, so this is basically an image that's created based on parts of the brain using glucose. So you can see on the top, those are Parkinson's disease patients who are off medication. And you see the increase in the red. Those are all areas of the brain that are active when you provide a painful stimuli. And on the bottom row, the very bottom, that's the area of the brain that's active and producing and burning more glucose when a normal person experiences the exact same stimuli. And what you can see is there's more areas of the brain activated in patients with Parkinson's disease, and when they take their medication, so on Cinemet, which is the second row, it actually starts to normalize. So we know that patients with Parkinson's disease do not process pain stimuli in a normal way, and that this is one of the things that gives rise to pain in the disease. So we talked about the classifications of pain. We talked about musculoskeletal pain, most common. We talked about pain due to dystonia, often happening in the mornings, or sometimes it can happen when you're getting on dystonia. We talked a little bit about the nerve pain that can occur in Parkinson's disease. It's much more of a given pattern, the type of pattern that you see with an individual nerve or an individual nerve root. We talked about the central or Parkinsonian type of pain that can sometimes occur. We talked about the restlessness, that akathisia, and just not feeling like you can sit still. That's a form of pain in Parkinson's disease. And we talked about gastrointestinal pain. This is a slide. It's hard to read from here, so I'm not going to go through it in detail. But basically, it puts them in the order of frequency that they're experienced. And you're always going to see gastrointestinal or musculoskeletal pain first. Usually in most studies, and it's been a little bit variable, the next one that's often seen is neuropathic pain, and then it goes down to the more rare types of pain like akathisia. Central pain is sort of in the middle, but I think for many people, central pain is not actually recognized as such, and so it gets overlooked. So now that you guys have a bit of an understanding of the lay of the land in pain in Parkinson's disease, you see how complicated it is. You've got a framework in your mind to see how it's classified. Let's think about the average patient who walks in and wants to talk about pain with their movement disorders neurologist. So this is someone that, let's say, is in their late 60s that has had Parkinson's disease for 6 or 7 years now. And first of all, in addition to having Parkinson's disease, they may have some degree of degenerative arthritis, right? So that's giving rise to pain. So that's noise in the signal. It's going to be there. There's nothing we can do about it as their movement disorders neurologist. They're going to mention it, but we're not. And our job is to have to try to separate that out from the pain that might be occurring secondary to Parkinson's disease itself. So you've got that pain going on in the background, and then maybe 3 weeks before there was a fall and there was an injury to the hip, and you've got the injury of the hip that's still sort of lingering over. And you're there to talk about pain. You're not thinking about all the ways that this is fractionated. You're throwing it all out there all together, right? So now we've got the osteoarthritis-related pain and the pain related to the injury that was already there before. And let's say Hess. So this is just a image that shows as you're going up, this is the ons and off of motor fluctuations, right? So you might have a patient who, when they're off medication, is experiencing dystonic pain and dystonia. And then as they start to turn on, the dystonic pain goes away, and then they hit a peak dose. And now they may actually be experiencing central pain related to Parkinson's disease. Or maybe they're more mobile now, and their neuropathic pain that was not triggered when they were less mobile and couldn't walk around is now flared up and ready to go, right? So now you've got a different type of pain that's happening in the lows of the fluctuations. You've got a different type of pain that's happening in the peaks, the times when the medication is working at its best. You've got the osteoarthritis in the background, and you've got the fall from 3 weeks ago, and this is all mixed together, and we've got 5 minutes to talk about it. So you see how complicated this is going to be, right? It's really, really tough to do. So I've written a book chapter on this. I've talked about it a number of times, and I'm still not happy with the way I address this. I think as movement disorders neurologists, we don't do a good enough job with this. It's one of the things that we all, I think, struggle with. So hopefully by allowing you all to come in with the most information that you can and the best preparation that you can, we can make the best use of the time that we have together. This is some of the factors that go into pain. It's a little too small, I think, to go into detail, but I think we've established the fact that there's lots and lots of factors and features that give rise to the complex phenomenon that we experience and know as pain. So how do we make the diagnosis of pain in Parkinson's disease? The most important thing is the history and the exam. It has to be blended in with everything else that we do because, as we talked about, when you come in for your visit, we need to talk about your bowel habits and constipation. We need to talk about whether you're getting dizzy. We need to talk about your mood. We need to talk about whether you're enjoying things, your appetite. There's so many different things that there are. We've got a little bit of time to talk about Parkinson's disease-related pain. However, that's the most important factor in evaluating what the next steps are to do. Sometimes we may order an X-ray or bone scans. Bone scans if you're looking for loss of bone density, X-rays if you're looking for broken bones, or if you're looking for abnormal growth of bone due to inflammation. Serologic tests can sometimes be helpful. A lot of times that's going to be sent to your primary care doctor to do. And this is something I'm going to talk more in one of the future slides. However, pain related to Parkinson's disease is complicated enough that it needs a team approach separate from the regular team approach that we already do as an interdisciplinary center. You may, if you want to address the pain that you have to involve your primary care doctor. You may need to involve a pain specialist. You may need to involve an orthopedic surgeon. You may need to involve a neurosurgeon. And all of this might take months to actually sort of play out. All that time, you're still having the pain. So as proactive as you can be is going to move you closer and closer to control of that pain in a short period of time as possible. So these are just some of the things that can help us to establish the diagnosis when someone's experiencing pain in Parkinson's disease. So treatment of pain in Parkinson's. We talked about being proactive. One of the things that you can sometimes do if you are experiencing a lot of other motor symptoms when you see your movement disorders neurologist or your neurologist is ask them to say, okay, I understand a complicated topic. I understand we can't talk about all the things that we need to talk about in the half hour that we have together, and in the last 5 minutes, I'm going to cure your pain. Why don't we set aside a specific visit that's just going to be about pain? So you can see one of the other providers to handle your fluctuations, or you can add a visit, but actually having a full amount of time, the full amount of time that we can spend with you just to address pain is a really good idea to do if you feel like you're not getting anywhere otherwise in addressing pain related to Parkinson's disease. And I talked a little bit about the team approach. Having a general neurologist locally who may be able to help with regard to your neuropathic pain. So many people have spinal stenosis or sciatica or pain related to the sciatic nerve, even if they don't have Parkinson's disease. So decreasing the burden by having little parts of this addressed by other providers and other diagnostic tests by other providers helps to make it move along as quickly and as easily as possible. And what's the most important thing? Bring that information with you when you come to your visit, right? Because we've got our half hour to devote purely to you. I want as much information as you can give me during that half hour to allow me to make the best decisions that are going to move things along to improve your quality of life as quickly as possible. So treatment of musculoskeletal pain in Parkinson's disease. Some patients actually will notice that their musculoskeletal pain gets better when they're appropriately dosed on Sinemet, right? So that's one of the things that we do the best at, because we're already adjusting your Sinemet anyway. Throwing pain in there into the mix as one of the variables that we're thinking about when we're trying to figure out what the best dose of medications for you is not that difficult for us to do. So that's more of an easy one to address. Not that you're going to respond, because as we talked about, there are patients who, when they're off, they're not really having much pain. When we actually improve your motor function enough that you're up and around and moving and going and walking, pow, sometimes the musculoskeletal pain that was hidden before because you're not doing very much comes out. So it's not automatic that we expect we just increase your Sinemet and your pain's going to go away. It's complicated, so that might happen, that might not, but it's something that we do a reasonably good job, at least, of thinking about with regard to other types of pain, which I don't think we do a very good job. Overall general pain relief. So musculoskeletal pain that's related to Parkinson's disease will often respond to the same type of treatment that your primary care doctor or a neurologist that is not a movement disorders expert is going to provide for you. So they can be helpful members of the team in trying to decide what to do. So Tylenol, Motrin, medications like that can sometimes be helpful. In patients who are very severe with regard to the degree of musculoskeletal pain that they experience, opiate medications may be appropriate. Now, that's not something that your movement disorders neurologist is going to go into with you, but there are some studies that have shown that opiates can be helpful in a subgroup of patients who have pain. So if you want to get into that group of medications, or if that's what's required, it's very likely that you're going to need coordination between multiple providers, and you're probably going to need to have a pain management specialist. Exercise and physical and occupational therapy are super, super important. So just by being here, you all are amongst the most educated patients who have Parkinson's disease. Most patients don't go out of their way to attend functions like this, even when it is available, when it's not in many places. So you're already at the right side of the curve with regard to this. And appreciation of the importance of exercise and occupational and physical therapy is something that I think you all appreciate more than the average patient. Some patients that I see, their visit with the therapist, whether it's speech therapy or physical therapy or occupational therapy, is actually more important than what I do, because I'm adjusting medications. Sometimes it goes well, sometimes it doesn't. The physical therapists are of the utmost importance, and so making sure that that's part of the interdisciplinary group that's involved in providing you the best care possible is really important. Some patients, if we get better control of their dyskinesias, their pain starts to get better. So as you can imagine, if you have dyskinesias in your neck and you're constantly moving your neck, and for some of you, you may experience dyskinesias when you are hitting a certain peak time, can be pretty significant, and it can give rise to degeneration in the spine and in the thoracic skeletal system. So addressing dyskinesia can be important, and making sure that you involve orthopedic surgery, pain specialists, and rheumatologic consultation. Let's say, for example, rheumatic arthritis is really important as well, because everybody's got a different level of expertise, and everybody's going to come to you with a different number of tools that they have in their box, and you want to have as much of this as possible focused on the problem that you have that you're trying to address. Treatment of dystonic pain. So adjustment of dopaminergic medications. This is something that we also do pretty well. We talk about dystonia. If we can recognize it and we can separate it from the other types of things that are going on, we can make increases or decreases in your medications. Let's say you're experiencing overnight dystonia, your toes are curling down in the morning, and we can address that by giving you a controlled release dose overnight. Or you're experiencing on dystonia, and we can shave your dose by half a pill. It's not going to cost us too much with regard to your motor symptoms, but we can actually take a big portion of that dystonia away. Those are things that we can potentially do. Sometimes other medications like amantadine can be helpful from that regard as well. Some of you maybe get Botox injections for your dystonia in the soles of the foot for the toes curling down, sometimes in the top of the foot for the toe that goes up. Sometimes if your foot goes in and downward, the way we talked about, Botox goes directly to the muscles that are involved in the movement if you put it in the right place, and that can be very effective in treating dystonic pain. Medications like anticholinergics, benzodiazepines, baclofen are variable. Some patients they work very well for. Some patients they just don't tolerate it, so it doesn't matter if it works anyway. But it should be something that you're considering. It should be on the menu and you make the conscious choice, no, we're not going to try that, and it's for this reason. If you do want to try one of these medications for dystonia or something else, you want to know what is your target, what are you trying to achieve, how are you going to measure whether you got there or not? Is it going to be based on what you describe? Is it going to be based on the UPDRS? Because any of these medications are going to have side effects, and we have to have a way to make the decision whether the benefits outweigh the risks. Deep brain stimulation can help in some patients with dystonia. It's not one of the classic things that we will describe. It's hard to predict whether it's going to help or not, but in some patients that can be helpful. So treatment of nerve pain in Parkinson's disease. There's a number of different medications that you can try. Some people have been on Cymbalta, some people have been on gabapentin, different types of anticonvulsants. Topical lidocaine helps, topical capsaicin helps for some people. Antidepressants. Keep in mind, a lot of these medications that started as an antidepressant or started as a seizure medication didn't do very good in what they were described or originally designed to do, but pharmaceutical companies put a lot of time and effort into these medicines, so they want to know if it doesn't help this, does it help this? And we found that medications have been repurposed over the years and can be very effective. And so if you're prescribed a medication that says antidepressant and you actually are on it you think you're on it for neuropathic pain, it might actually work, so don't be thrown by that. Again, opiate medications for some patients can be helpful in nerve pain. That's usually only the most severe patients. Physical therapy is always important. Postural hygiene, splints and braces may be a part of what works for you. Appropriate orthopedic or neurosurgical referral can be important. Cannabinoids. So this is the first time you're seeing this word on the slides today, but I bet this is the one that all of you were thinking about, because when you see Parkinson's disease and you think of pain, the first thing you're popping into your mind is cannabinoids. So we're at a point now to where it's really difficult to get a sense of how helpful this is going to be. There is some sense that it actually will be helpful for nerve pain. It may also be helpful for musculoskeletal pain. There's a couple of studies that have suggested that. I didn't put it in the list for musculoskeletal pain because it's just too premature. In the state of Florida, we do have access for Parkinson's patients to cannabinoids, and some of you in the audience maybe have taken them and have actually had a benefit for pain. So it's definitely a possibility. It's a little early for us to know from a research standpoint if we can sort of put our rubber stamp on it and say this is something that we think is going to help you. I can say for most patients, for the vast majority of patients that have tried it, the risk of side effects has been relatively low. The biggest hit has been in the wallet, right? And then other times it just doesn't work. But most of the time, it's not going to actually cause problems for you because the parts of the brain that are involved in Parkinson's disease also have these types of receptors. Akathisia. Although it's rare, when it happens, it can be truly disabling and miserable. So sometimes it responds to dopaminergic medications, sometimes it does not. There are patients that have responded to clozapine, which is an older antipsychotic medication that some of you might have been on. That's the one that people, if you're not on it or if you've discussed it, requires the weekly blood draws because otherwise it can cause agranulocytosis. Opiates, dopamine agonists, gabapentin are all used for restless leg syndrome, but the reason I listed up there is when you're talking about akathisia, you have to think about restless legs because they're so commonly mistaken for each other. So you want to be, if you have a diagnosis of restless legs and nothing's working, make sure they go back and think about, could this be akathisia? Because maybe that's what it is and it's not related to restless legs directly. GI pain can sometimes be treated by medications that increase gastrointestinal mobility. Some of you might be on Linzess or Amitiza. Some of those medications can be helpful. Increasing your water intake or your fiber intake can be helpful. Changing the times of day that you eat can sometimes be helpful as well in reducing the type of pain that sometimes develops. So these are things to keep in mind. Treatment of central pain in many patients can be treated by dopamine. And a good number of patients actually, when they're well medicated, the central pain goes away, and in their offs, that's when it starts to come back. So that's the first thing that you need to think of. It might work, it might not. Some of the other things that are listed here, antidepressants, anticonvulsants, you're seeing a trend here, right? These are medications that you've seen on previous slides, and they're not up here because they're so perfectly effective. They're up here because We're trying to find what's going to work best with what we have available. And so we have to try things and take what we can get because we don't have a great way right now to address this. We can't address it in the same way that deep brain stimulation, for example, addresses the rigidity and the stiffness and the dyskinesia so well. We're doing our best with this, but we're behind the power curve with regard to actually making a big difference with this. Okay, so we've gotten through pain, hopefully without too much pain. We're about 20 minutes from lunch, so if you're getting hungry, there is light at the end of the tunnel. And so now we're going to try to spend the rest of the time. We might actually finish a little bit early as well, so hopefully we can start eating a little bit early. So we'll spend the rest of the time talking about fatigue and Parkinson's disease. So in our little cohort here, when I asked everyone to raise their hands, we had more people that were experiencing fatigue than we were experiencing pain. Now, just like pain in a population of middle-aged to older people, fatigue is very common. Anybody who has kids is going to say, yep, I've got fatigue. Anybody who works multiple hours per week is going to say they have fatigue. But the fatigue that patients with Parkinson's describe is completely different than what people normally mean when they're talking about fatigue. So we'll talk more about that. We'll talk about how common it is. We'll talk about what other symptoms are associated with it, when it occurs, what the treatments are. But there's one take-home point that I really want you to take with you, and that's separating fatigue from its closest mimic. And so we'll talk a little bit about that. Are we still okay on time? 5 minutes. We can do fatigue in 5 minutes, no problem. Okay, so what is fatigue in Parkinson's disease? It's a state of extreme tiredness, nonspecific weakness, lack of energy, or exhaustion. Patients who have Parkinson's disease and experience fatigue describe it often like you've just run the New York City Marathon. It's not that you're tired, you're just completely wiped out, and all you did was your normal day-to-day activities. Fatigue doesn't have to be physical. You can have mental fatigue and feel like you've just taken the entrance requirements to join Mensa, and all you did was make your coffee in the morning. So this is not unusual. So you can have mental fatigue in the same way that you have physical fatigue. And stress can modulate it a lot, okay? So it's 30 to 70% of patients with Parkinson's disease. Look at these numbers. This is the same type of magnitude of numbers that we were talking about when we were talking about pain. Tremendous number of patients with Parkinson's disease experience fatigue. About 15 or 30% of patients actually rate it as the number one, on top, most disabling symptom that they have. Doc's done a great job of controlling my motor fluctuations, my tremor's gone, I'm walking, I'm doing well, but I don't do anything because I'm exhausted all the time. And I'm not sleepy. I don't go and take a nap. I'm just exhausted. And that's the key feature that we're going to talk more about. In some patients, that disabling, overwhelming fatigue can be the presenting symptom that you actually have. It can happen before you see the motor symptoms, before you see the tremor and the stiffness and the rigidity. In some patients, it correlates with severity or disease progression. Sometimes it doesn't. Sometimes it comes and goes throughout the course of the day, and sometimes it's there just all day long. It can be associated with depression, apathy, or inability to join things, or inability to feel pleasure. All the patients who experience this as well tend to experience a worsening in the fatigue that they have. So this is that take-home slide that I meant to tell you about. So if you go to your doctors, your movement disorder specialist, and you say, I have fatigue, you want to be very careful that what you're talking about is what we just described and not excessive daytime sleepiness. If you're waking up multiple times to urinate and you wake up in the morning and you feel like you didn't even get any sleep and you're taking naps throughout the day and you don't have any energy to get up and do everything and you're always falling asleep, you have excessive daytime sleepiness. Your problem is not fatigue. You can have fatigue associated with excessive daytime sleepiness, but if you have fatigue and it gets mislabeled as excessive daytime sleepiness, you're going to spend months going down the wrong road. And the same thing the other way. If you have fatigue in people or excessive daytime sleepiness and it's being treated as fatigue, you may not get anywhere. So you have to be very, very careful when you go to see your provider, whether it's a movement disorders neurologist or not, that you understand and are thinking about, is my problem that I'm falling asleep multiple times a day because I'm always sleepy, or is my problem that I have that overwhelming sense of fatigue that we talked about earlier, and I got up, had breakfast, made coffee, and I needed to go lay down. I didn't go to sleep. I just couldn't do anything else because I was so fatigued. So if you take nothing away from this component of the talk, if you can differentiate between those two, you'll already be ahead of most patients who have the disease. So treatment of fatigue, first of all, you have to figure out what component is related to excessive daytime sleepiness. We may need to send you for a sleep study. We may need to provide medications to help to consolidate your sleep overnight. We need to take that out as a variable to see what's left over after we correct it. In some patients, you can use the same type of medications that you can use for depression, so SSRIs, TCAs, so medications basically. It helps in some patients it doesn't do anything. Exercise can be helpful in some patients, but it's not a cure-all. There are studies that have shown that some patients do not have an increase in fatigue when they exercise, when you specifically look at the fatigue that we're talking about here. Sometimes other medications like MAOB inhibitors, so selegiline, for example, this is a trick if any of you in the audience have ever seen me that I sometimes use. Selegiline is, when it's metabolized in the liver, produces a small amount of amphetamine. And you can use that byproduct to provide a little bit of pep during the day. And it can work very well. It can be well tolerated. So it's one of the first things that we can do that's very easy to do. There have been studies that have suggested rasagiline can also help with daytime fatigue. The studies for the dopamine agonist is variable, and levodopa is also variable. In some patients, the levodopa actually worsens the fatigue. In some patients, it actually makes patients feel like they have more energy. For patients who have severe symptoms, either methylphenidate or modafinil are medications. These are medications that we give to people with narcolepsy usually, are reasonable and worth trying. It doesn't always work. Sometimes you have to weigh the risks and benefits, but that's also a possibility. There are some patients who've responded with regard to fatigue to DBS, but that's not a reason to get DBS because it's very difficult to predict, and more likely than not, it's not going to make a difference. So we made it through fatigue in almost 5 minutes. We talked about the different aspects that play a role in the development of pain, how complicated it is to study and to address, and now hopefully you have a lot more ammunition and a lot more understanding of what it is that's going to need to be dealt with if we're going to defeat this. And in the same way with fatigue, now you know how to separate it from excessive daytime sleepiness, so you're not going to waste 3 months with your movement disorders neurologist trying to sort out between the two. And hopefully this type of information and talking to your care provider and investigating online at sites like the Michael J. Fox Foundation, the Parkinson's Foundation, the Davis Phinney Foundation can help us to beat the symptoms of the disease and improve your quality of life on a day-to-day basis. Thank you all for your attention. So I put these slides up here. I know you saw them in Dr. Oken's talk already, but for those of us that provide the care, the best care that we can for you, having a center like this is a dream come true because it really allows us to provide the best level of care that we can. So we're super excited about it. If you do get your care at the Movement Disorders Center here in Gainesville, don't go to the wrong place in 3 months because we're going to be at our new location. That's the address up there, and you should be getting phone calls and mailings to remind you so you don't, on autopilot, go back to the orthopedic center. Now, if you have some types of pain, they may be able to help you at the orthopedic center, but you're going to be really late for your appointment, so make sure you go to the right place. Take care.